Hello everyone, and I am Dr. Anupama Chowdhry Devgan. I will be discussing the physiology questions in the INICET NEET 2022 exam. The questions, my overall assessment of the type of questions that were asked, there were a few repeats. So it becomes extremely important to do your previous year's papers, and also to concentrate on our AIIMS capsule, besides of course your class notes. Like for instance, this first question is from the class notes, which we do so much in detail. What causes detachment of the myosin head from the actin head from actin during a muscle contraction? And now to understand this, you have to look at the actin myosin cross bridge cycling. And to understand the actin myosin cross bridge cycling, please remember that at rest, the myosin head, this is in a high energy, high affinity state. High energy, high affinity state. What do I mean by that? That means the myosin head is ready to bind with actin, but the only reason why it cannot do so is because tropomyosin covers the active sites on actin. Now, as soon as calcium becomes available, then it binds with troponin C. There's a conformational change in troponin. It causes the tropomyosin to slide, and what gets exposed are these active sites on actin. The moment an active site on actin is exposed, the myosin head will bind with its active site on actin by reversible bonds. Now remember, it was in a high energy state. It will utilize that energy, and the head moves in this direction. Head moves towards the tail. And as the head moves towards the tail, it will also pull actin along with it. Now the next step here is ATP attaches to the myosin head, and as soon as ATP attaches to the myosin head, this now causes a conformational change, which now leads to detachment of head. For detachment of head, no energy is being used. Where was energy used? In what is known as the power stroke, when the myosin head bends towards the tail and it pulls actin along with it. That is known as a power stroke, right? Power stroke. Energy was used for the power stroke. So like I said, ATP attaches to the myosin head, a conformational change causes detachment of head, and that same ATP which has been attached is now going to be hydrolyzed. So there is a hydrolysis of ATP. The myosin head has an ATPase enzyme which will cause the breakdown of ATP to form ADP plus inorganic phosphorus plus energy, and the head goes back into that high energy, high affinity state. And the question which has been asked in this year's INICET, what causes detachment of head? And that is the attachment of ATP. Attachment of ATP causes a conformational change and a detachment of head. No energy is being utilized for detachment. And please also remember that detachment of head does not mean relaxation. Relaxation only happens when calcium goes back into the sarcoplasmic reticulum, and then the cycle stops here. Myosin head will be at that high energy, high affinity state. So answer to this question will be binding of ATP or attachment of ATP, which causes detachment of head. Now, this is, which of the following is the physiological mechanism of TENS? Now, this is again something which is a direct question from your class notes. And TENS, the full form of TENS is transcutaneous electrical nerve stimulation. Right? Transcutaneous electrical nerve stimulation. Now, what is this transcutaneous electrical nerve stimulation? A very common kind of an experience. Whenever you are in pain, you rub that area. By rubbing that area, you will stimulate a large diameter myelinated touch fiber. And this large diameter myelinated touch fiber that is going to be stimulated, that is A beta. Again, this is a question which has been asked. Which touch fiber is stimulated in the gate control mechanism? Now, the central process enters into the posterior part of the spinal cord, ascends upwards. Now, let us see what is the anatomical connection between this small diameter, unmyelinated C fiber conducting sloping. Now, this C fiber, it synapses in the dorsal horn of the spinal cord, and the second order sensory neuron crosses over to the opposite side and ascends upwards. Now, this touch fiber gives a collateral which synapses with an encephalinergic neuron present in the dorsal horn, and this encephalinergic neuron forms an axo-axonal synapse with the presynaptic neuron, in this case the first order sensory neuron of the pain pathway. So when I gently rub the area, impulses will go via the peripheral process, via the central process into the spinal cord, and impulses will go via this collateral to this encephalinergic neuron. Encephalinergic neuron releases enkephalin, and it now causes a hyperpolarization of the presynaptic membrane. Presynaptic membrane is the first order sensory neuron of the pain pathway. And because there is a hyperpolarization, there is a decrease in the release of the neurotransmitter. This is known as a presynaptic inhibition. And this mechanism is known as the gate control mechanism. Let's look at the next question. It says countercurrent mechanisms are found in which of the following? Now, countercurrent mechanisms are found in the testis, in the gut, in the intestinal villi, kidney, of course, there is a countercurrent multiplier, there is a countercurrent exchanger, lungs. Now, I'm not sure whether the lungs were there in the recall or not. One student sent me that lungs was also there in the recall. Lungs, a little controversial, definitely. Lungs, in the case of animals, do have countercurrent mechanisms. Some authors have said, yes, there are countercurrent even in the alveoli. So we will have to take this also as a correct option, but I does not have any countercurrent mechanism. So in this case, if you're going with these options, if these were present, then B, C, D, E are correct. Next question, again, this is something which we do in class, and that is two blood vessels A and B have a laminar blood flow. In the blood vessel B, diameter and length are doubled. Now, what is flow? Flow is equal to delta P by R. Flow is directly proportional to the pressure difference at the two ends of a tube divided by the resistance to flow. And what is resistance? Resistance is 8 neta L over pi R4. This is the Hagen-Poiseuille's law, or Hagen-Poiseuille's formula. Neta is viscosity, L is length, and R is radius. Now, when I substitute R in the first formula, I get flow is equal to pi by 8 into delta P radius to the power 4 divided by neta L. In other words, flow is directly proportional to the fourth power of radius, and flow is inverse to the length. Right? Now, there are these two options where in the second tube the diameter is twice and the length is also twice. So what is going to happen to the flow? Flow will be directly proportional. So 2R raised to the power 4 divided by 2L. So that means 16R divided by 2L. In other words, this becomes 8 times the flow in the first tube. 8 times the flow in the first tube. The flow in the second tube will be 8 times the flow in the first tube. So my answer here will be 8 times. This is also a question which we do very often in class. Physiological adaptation at high altitude. Again, this is something which is there in your AIIMS capsule. Physiological adaptation at high altitude, pulmonary vasoconstriction, definitely. Hypoxia will produce a pulmonary vasoconstriction. Hypoxia produces a dilation everywhere except in the lungs, where it produces a pulmonary vasoconstriction. Why it does that is because the pulmonary blood vessels have got different potassium channels as compared to the other tissues. Pulmonary blood vessels have got oxygen-sensitive potassium channels, yes, whereas the other tissues have got ATP-dependent potassium channels. So the effect of hypoxia on the blood vessels in the lungs is a vasoconstriction. Is there going to be an increase in heart rate? Definitely. There is a hypoxic hypoxia, and which will stimulate the chemoreceptors, which will not only stimulate the ventilatory, the respiratory system, but also the cardiovascular. So increased sympathetic discharge in high altitude, definitely. Polycythemia, definitely again. A decreased PO2 will cause an increase in erythropoietin. Hypoxia is a very potent stimulus for erythropoietin secretion, and erythropoietin increases the red cell mass. Yes. Physiological adaptation at hypothermia is not really an adaptation. Hypothermia will be, it happens because at high altitude. So it's not really a physiological adaptation. So no, I will not agree with hypothermia. Respiratory acidosis. No, I do not agree with that. Also, this is because what happens when there is a decrease in PO2 which occurs at high altitude, this is a hypoxic hypoxia. It will stimulate the chemoreceptors, the peripheral chemoreceptors. It stimulates the peripheral chemoreceptors, and the peripheral chemoreceptor response is to increase the rate as well as the depth of ventilation. And when there is an increase in the rate and depth of ventilation, we say there is an increase in the total ventilation, and there is also an increase in the alveolar ventilation. Or this is known as, when there is an increase in total as well as alveolar ventilation, it is hyperventilation. And the effect of hyperventilation is a CO2 washout. And CO2 washout will result in alkalosis, a respiratory alkalosis. So acidosis is not a possibility at high altitude. In fact, what you see is an alkalosis. Yes. Increased cerebral blood flow. Hypoxia will produce a cerebral vasodilation. I told you hypoxia causes vasodilation everywhere except in the lungs. So increased cerebral blood flow will be seen in high altitude. Let's have a look at the next question. Again, this is something which I've discussed in the AIIMS capsule. This is a repeat question. In fact, it has been asked a few years earlier. In the following graph, the line N represents the normal relationship between alveolar ventilation and PCO2 when PO2 is kept constant at 100 millimeters of mercury. If the pH is changed from 7.4 to 7.3, where would the original line shift? Now, basically, this is showing you the relationship between CO2 and alveolar ventilation. And we know that as CO2 increases, there is going to be it will stimulate the peripheral and the central chemoreceptors. And that results in an increase in rate and depth of ventilation, or increase in total as well as alveolar ventilation. Now, the relationship between CO2 and alveolar ventilation is almost a straight line, as you can see. This is, so more the CO2 levels, I'm just going to, more the CO2 levels, more will be more the CO2 levels, more will be the alveolar. It's like a linear response. With increase in CO2, there is going to be increase in the alveolar ventilation. Now, one thing that you have to notice here is how much is the normal arterial CO2? The arterial CO2 is 40. So at 40, you can see that there is some effect on alveolar ventilation already at a normal PCO2 in the at a normal PCO2 level, there is some effect of ventilation. What I'm trying to say is basically, this line is not starting from 40. The starting point is somewhere between 30 millimeters of mercury and 40. So at a normal CO2 level of 40, there is some basal level of stimulation of the peripheral and the central chemoreceptors. Now, this is seen when the PO2 is constant. PO2 is at 100. Now, supposing I lower the PO2 and take it to 60, right, which is hypoxia. What will happen to the CO2 response curve? This is also, this is known as the CO2 response curve. We find that the slope increases. This is when the PO2 is reduced to 60. The slope has increased. What does that indicate? That indicates that the sensitivity of the chemoreceptors to CO2 has increased in the presence of hypoxia. Yes, so this is your line A. Now, if I further decrease the CO2 levels, I find that the slope increases even more. Yes, the slope increases even more, again indicating that the sensitivity has increased even further. So this is seen when the PO2 is 50, this is at 40. These are your lines A, B, C. Now we got that, right? Sensitivity of the chemoreceptors to CO2 has increased in the presence of hypoxia. Now, the next important point is what is causing this shift of these fan of lines, these are called fan of lines, to the left. If you can see this, all these lines have now shifted to the left. Yes? What causes this shift? This shift is seen in acidosis. When the pH has changed to 7.3, the first set of lines were when the pH was normal. Now the pH has been reduced to 7.3. So what has happened is all these lines have shifted to the left. Again, what does that indicate? That indicates in the presence of acidosis, the sensitivity of the chemoreceptors to CO2 increases even further. There's a much greater increase in the sensitivity. Right? This is what is causing a shift of these fan of lines to the left. So my answer to this question will be D. D is the answer here. The line which is parallel to 100 to N, the normal line, but starting from the left. So the answer to this question will be D. It says when the pH is changed from 7.4 to 7.3. Note a cause of central cyanosis. Now, central cyanosis will be seen whenever the deoxygenated hemoglobin is increased. Deoxygenated hemoglobin is more than deoxyhemoglobin is more than 5 grams percent. Yes. Some books also say this is if it is more than 4 grams percent, or if methemoglobin is more than 1.5 grams percent, or if sulfhemoglobin is more than 0.5. So this is what is going to cause a central cyanosis. Pulmonary arteriovenous fistula, definitely. Methemoglobinemia, yes. High altitude, there is going to be decrease in PO2 as well as a decrease in saturation. You might see a central cyanosis. Hypothermia is not going to cause, or exposure to cold is going to cause more of a peripheral cyanosis rather than central. Given below are the substances and the mechanisms of transport. I'm again not sure of the options, but from the students what I've got is oxygen by simple diffusion, respiratory gases by simple diffusion, yes. Glucose by facilitated diffusion, that is true. Glucose is transported by secondary active co-transport in the lumen of the intestine, kidney, and by facilitated diffusion on the basolateral membrane in the intestine, in the PCT. Also, you have facilitated diffusion, glucose transporters are present in the RBC's brain. That's how glucose enters into the cells. So facilitated diffusion, that is GLUT, yes. Sodium by secondary active transport, yes, sodium is transported by primary as well as secondary active transport. Calcium by primary active transport, yes, there is the movement of calcium from the sarcoplasm into the sarcoplasmic reticulum is by SERCA, which is a primary active transport. You also have secondary active transport for transport of calcium. Sodium by voltage gated, ligand gated channels, yes. So as per, if these are the options, then all my options are correct. Shown below is the conductance of two ions during different phases of the action potential. And which are these two ions? Now, these two ions, of course, again is something which is there in your AIIMS capsule, and this is which of the following pair of ions corresponds to the graphs A and B, and that is sodium and potassium. The upstroke of the action potential is because of opening of fast voltage gated sodium channels, sodium influx. So from almost zero conductance at rest, the membrane conductance for sodium shows a sharp increase, which is responsible for the depolarization phase. Then the sodium channels are fast channels, fast to open, fast to close. They very rapidly close, and the conductance for sodium decreases and becomes almost zero again. What about B? The second graph is for potassium. At rest, the potassium permeability is much more than that for sodium. We know that at rest, the cell membrane is almost freely permeable to sodium. So almost freely permeable to potassium. So potassium permeability is much higher than that for sodium at rest. And then the opening of slow voltage gated sodium channels will increase the conductance for sodium, which is responsible for the repolarization, and then a slow closure of the potassium channels. So A is sodium and B is potassium. So these are your questions in physiology. If you have any queries, please feel free to send me a mail at dranupama@gmail.com. Thank you so much, and all the best.